So Dr. Saam Morshed is one of our co-faculty here at UCSF in the Adult Trauma Division. He's a professor of orthopedics, the co-director of the Orthopedic Trauma Fellowship at UCSF, as well as he co-directs the Global Research Initiative at the Institute of Global Orthopedics and Traumatology. He's a member of IGOT and a director of Clinical Research Center at the Orthopedic Trauma Institute here at UCSF. So Caitlin's going to play the video, which is a pre-recorded talk, and there are parts of it which may be a little speeded up for time's sake, but I think it's very comprehensible. So Caitlin, can you please play the tape and I'll stop sharing.
Hello, my name is Saam Morshed, and I'm going to be speaking about considerations around limb optimization following severe traumatic injuries. I don't have any relevant disclosures with regards to the topic of this presentation. And I'd like to start with a case. This was a young woman who was injured in a dirt bike injury. I met her about 8 years ago. She was an 8th grader from Oakland, California, normal young lady with a strong family support, motivated academically and athletically, with this really devastating medial column fracture dislocation with a significant soft tissue disruption. This is an image after her initial debridement. You can see here a significant bone defect involving the medial column of her foot. And when we see injuries like this, I think many of us surgeons consider this maybe a salvage versus an amputation consideration. I like to think about reconstruction as the proper way of phrasing an attempt at keeping the foot or part of the terminal affected limb. And I'll explain a little bit more why later in the presentation. It's important to think about what factors matter most in determining this young woman's outcome. And so the objectives of this talk are going to be to summarize the evidence. Unfortunately, there's a little evidence to guide this with respect to comparative literature in children, but I'll summarize to the best of my ability that which I understand in the adult population. We're going to review conditions where amputation may be a favorable option, discuss evolving therapies available to both persons with amputations and those undergoing limb salvage or reconstruction. And we're going to talk a little bit about ethical considerations in our role in considering the patient's autonomy in the shared decision-making process, which is very difficult. The decision to reconstruct or amputate an ankle lower limb following trauma is not an easy one, and it's an old question. In 1987, Ted Hansen in Seattle declared in an editorial that limb reconstruction surgery following Castillo-Anderson type 3C tibial fractures frequently left patients divorced, demoralized, and destitute. In an era bristling with the promise of improvements in microsurgeries, commentary memorably questions the notion that a patient's amputation is a surgeon's failure, and suggested that many patients may suffer far less with an early appropriate amputation. There'd be another 15 years of moderate to low quality clinical research and an animated debate on the topic before substantive progress was made in answering this question. Then in 2002, the main outcomes were reported from the high quality prospective multi-center cohort lower extremity assessment project, or LEAP, using rigorous methods and validated health related quality of life outcomes and measures and recording of healthcare utilization. They provided granular data from follow-ups of up to 7 years for over 500 patients with lower limb threatening injuries. In their primary results manuscript, they provided surprising results that there were no differences in the generally very poor outcomes, with only about half of patients returning to work by 2 years. But even at 7 years, no differences in the primary outcome is measured with a sickness impact profile, with both groups showing further decline in function and over half still severely disabled. Another crucial contribution from LEAP was how they enlightened surgeons as to the importance of psychosocial determinants of health. They introduced terms like self-efficacy, one's belief in their own ability to accomplish specific tasks, into the orthopedic lexicon. In this table, you can see that as we go from the highest to the lowest quartile of self-efficacy and social support, we see an almost twofold increase in the time required to return to work. We also know that for the subgroup of severe ankle and hindfoot injuries, that this ambiguity between treatments fades, and those undergoing flap or fusion reconstructions demonstrated decidedly worse outcomes. This and some concordant literature from the military would guide future studies to focus on this particular at-risk subgroup of patients. As the results from LEAP were trickling out into the literature, casualty care from the wars in Iraq and Afghanistan following 9/11 allowed us to focus on gaps in knowledge and test the generalizability of what we learned from LEAP. There were a lot of servicemen and women surviving blast injuries due to improvements in body armor and other protective technologies. This meant that there were many more extremity injuries among these survivors for our military colleagues to treat and study. Perhaps the most well-known of these studies among American wounded warriors was the MEDALS study. And this study showed that with an average of 3 years of follow-up, amputees had higher levels of physical function, lower PTSD, and higher rates of return to vigorous sports. In an effort to take what we learned from LEAP about poor outcomes with salvage of severe foot and hindfoot injuries and see if findings from MEDALS and other military cohorts hold among civilians, we designed a new prospective cohort study asking specifically whether patients with such injuries would have better function had they undergone an amputation. This table shows the main results of this study, called the outlet study. A positive difference here means that the salvage patients would have had a better outcome had they undergone amputation. All domains of the SMFA outcome instrument showed improved outcomes under amputation for all categories. with many being statistically and even clinically significant among the mobility domains of this instrument measured. Thus, salvaged and reconstructed patients with severe distal tibia and/or hindfoot injuries have SMFA scores that are worse than their predicted outcomes under amputation. The differences, again, were most notable for open pilon fractures and ankle fractures requiring flaps. What do we know about long-term outcomes? Well, just a little bit. Amputations happening greater than 90 days happen more commonly in the military and are most often performed for pain control. Most studies have shown that delayed amputations can lead to functional outcomes as good as those undergoing early amputation. And both early and delayed amputations did better than patients within reconstructed cohorts. Still, there does seem to be a cost to delaying an amputation in these populations, with higher rates of anxiety, depression, and substance abuse recorded. We provided really interesting information about the accrued lifetime direct costs for amputees and reconstructed patients. While the initial costs were very similar between amputees and reconstructed patients, over the life of patients, costs were estimated to be 3 times higher, largely due to the estimated cost of prosthetics. Given the advances in prosthetics and orthotic management that we're going to talk about, it'll be interesting to see if how these comparisons would hold up today. One of the biggest indirect costs to society are work productivity loss. A recent study from the Metric group demonstrated that these patients with high energy lower extremity trauma resulted in an average loss of more than 3/4 of annual wages, with those undergoing amputations faring among the worst. Finally, the mental health repercussions of these injuries are awful, with about 40% of subjects showing signs of moderate to severe depression, anxiety, and PTSD. We've heard so far that amputations may be medically necessary and may decrease pain and improve mobility compared to with limb salvage after similar injuries. However, does this necessarily result in improved health over the long term? Up until recently, we lacked such data. However, in a carefully matched cohort of 110 service members that underwent flap-based reconstructions that were either continued with salvage or were amputated, the amputation cohort tended towards higher rates of obesity than reconstructed patients after 1 year, with both groups at or above 50% by 10 years. The development of any metabolic comorbidity, including diabetes, hyperlipidemia, or cardiovascular disease, was also greater than 50% by 10 years. So it seems like limb loss may negatively impact metabolic regulation and may contribute to a higher risk of obesity in the long term. While it seems like amputation may be winning at this stage, there have certainly been remarkable strides made in orthotics and rehabilitation for patients undergoing a reconstruction pathway. It may not surprise you that I treated my patient, Carly, with a reconstruction. She underwent 2 free flaps, a free fibular flap to reconstruct her medial column, as well as a ALT flap to provide soft tissue coverage. And this resulted in a really nice outcome. As you can see here, at 2 years, she's healed with a nice soft tissue envelope. She's got not a perfect outcome, however. Let's understand that these reconstructed patients often still suffer impairments. They've been shown to experience a host of gait and balance disturbances, including slower walking speed, deterioration of balance, and associated proximal injuries or weakness can pose other limits for these patients. There are many different orthoses that have been developed to meet the needs of patients based on their deviations. None of these were particularly novel or were ready to meet the complex needs of the wounded warriors returning from the wars in Iraq and Afghanistan with salvaged limbs. This led to the development at the Center for the Intrepid in San Antonio of the IDEO, or the Intrepid Dynamic Exoskeletal Orthosis. It goes by different names now commercially. This was the first of a new class of passive dynamic AFOs that were born of an attempt to bring together many of the desired functions of commonly used orthoses, such as a traditional leaf spring AFO, carbon fiber, and UCBL orthoses and dorsiflexion assist devices. At the site of its development, this device, in combination with a rigorous return to run program, was shown to improve function, return to work, and ultimately change the minds of some 80% of wounded warriors who were initially requesting an amputation. We know that PDAFOs, along with rehabilitation, reduce rates of late amputations down to about 20%. They improve function and performance. These devices fail miserably for those with CRPS, chronic pain, and serious psychiatric distress. Specific groups that benefit are unknown at this time, and this is an area of active research currently. Here at UCSF, we've attempted to develop a service that meets the multidisciplinary needs of this complicated group of traumatic, pediatric, and oncologic patients facing limb viability questions, with the intention of putting our patients at the center. And what exactly do I mean by that? Well, it means avoiding framing of limb viability situations around the long-term goal of saving a limb, because an amputation then is counter-framed as a loss and therefore a failure. I think it's really important to respect the autonomy of our patients and favor the presentation of amputation as a reasonable and perhaps even favorable treatment option for functional limb restoration. Remember that after the haze of the initial trauma begins to lift and patients begin to calibrate their expectations and reflect on their values, your words and how you frame treatment really matters. How might these 3 ways of expressing treatment options be interpreted by your patients? After listening to patients and loved ones, hearing their fears and hopes, I try to frame my recommendations within a framework of one shared goal, limb optimization. And I explain carefully that this may be achieved with or without the terminal portion of their affected limb. Remember that these are hard and time-consuming discussions, unlike any other that I have with my patients, and there's no one right answer. I thank you for your attention.